please. I'm amazed to see so many of you here. Seems to me like every time I come to this room, I have to pay. I guess you figured, well, it's free. How bad could it be? Well, as was alluded to, I'm Tim Corey, and I am a dermatologist. For many years, I had a private practice in northern New Jersey in a town called Ridgewood, which is a New York suburb. And I also worked and taught at Columbia, which is shown here. This is the Columbia Presbyterian Medical Center. All of these big buildings here. And for many years, that was the largest private medical center in the United States. In recent years, it's teamed up with the New York Hospital and Cornell Medical College. And so between the two campuses now, it's absolutely enormous. This is where I work now, the Boca Grande Health Clinic Annex. But they do have something in common. They're both on islands. If I were giving this talk 10 years ago, I might ask, who here has had skin cancer? But I can't do that anymore. The government, in their infinite wisdom, and the HIPAA laws guards judiciously our medical privacy. So I can't ask anything like that, or they'd probably haul me off to jail. My goal here, though, because I think a lot of you have more than academic interest in skin cancer, I think you're probably here because I may not be the only one here who's had it. So I think you may have some personal interest. So I'm going to try not to be too long-winded and leave plenty of time for questions. My talk is entitled, The Sun, Friend or Foe. You probably think because I'm a dermatologist, I'm going to say the sun's absolutely terrible. Well, not necessarily. Without the sun, life as we know it on Earth would not exist. More than 3 billion years ago, the chlorophyll molecule evolved, which enabled plants to capture energy from the sun. This process is called photosynthesis. Carbon dioxide and water are taken into the plant cell, and using the sun's energy, longer chain carbon molecules are formed, and oxygen is released as a byproduct into the air. This is the basis of all of our food, either directly in plants that we eat, or indirectly when we eat animals which consume plants, or eat smaller animals who then eat plants. The breakdown of the high-energy carbon chains formed in the plants releases that stored solar energy within our bodies, which allows our lives to proceed. Photosynthesis is also the basis of all other energy in the world, with the exception of nuclear energy. Fossil fuels, again, are the result of photosynthesis. Wind and water power are indirectly related to the sun's energy. The uneven heating of the planet by the infrared rays of the sun cause the winds. Solar evaporation of water and its subsequent falling as rain from the atmosphere is what's responsible for water power. Obviously, solar generation of electricity directly uses the sun's energy that way to make electricity. Another benefit of sunlight is vitamin D production in our bodies. The ultraviolet B rays transform precursors in our skin to vitamin D, which is then further metabolized in the liver and kidney into its active form. But you knew a but was coming. The sun is not all good for us. This diagram shows the electromagnetic spectrum of the sun. The shortest wavelengths, which have the highest energy, are the gamma rays and the X-rays. These are very high power rays, and fortunately, all of these wavelengths are totally blocked by the Earth's atmosphere. Otherwise, we wouldn't be here very long. We'd be totally cooked. The visible light, which is this narrow part of the total spectrum, is what we're familiar with. This is what we see. This is also the part of the light of the spectrum which is used in photosynthesis. The part of the spectrum just beyond the red light is called the infrared. Although we can't see it, we can feel it. That's what we feel as the heat from the sun, the infrared. The ultraviolet rays, which are just beyond the violet end of the spectrum, are the troublemakers. The UVA and the shorter UVB rays play a role in skin aging, also in eye diseases, especially cataracts, and in skin cancer. Ultraviolet can also suppress the immune system in the skin. Sometimes this can be useful, as in psoriasis. Sun or artificial ultraviolet light can be used to treat the psoriasis, or also certain cutaneous lymphomas, in which the immune cells are damaging the skin, and the sun's effect can help to ameliorate that. But of course, the sun can also be harmful, since by lessening the immune surveillance in the skin, it helps to lessen the body's ability to keep skin cancer at bay. Ultraviolet rays can also cause damage to the DNA in the skin, and this is what can result in mutations, which can lead to skin cancer. Of all the ultraviolet rays that reach the Earth, 5% of them are UVB rays. These are the rays that can cause sunburn. 95% of them are UVA, or the longer waves. Although UVA rays are the less powerful, they are the more abundant. They can penetrate clouds, and they can penetrate glass, unlike UVB. You, of course, can't get sunburn through the window. UVA also penetrates the skin more deeply than UVB, and UVA is the more important tanning ray. Tan is the skin's response to damage. In our era, we've been conditioned to think that a tan is attractive, but it's really a sign of damage to the skin. It is as if we complimented our friend's car saying, "Oh, how nice your car looks with those dents." UVA is also what is produced in the tanning booths, or the tanning beds. The UVA in these machines is released at 12 times the output as is released from the sun energy. UVA and UVB together are responsible for the DNA damage, which can lead to cancer. Sunburn is a response to the sun that we're all familiar with. This is a direct effect of UVB on the skin. There are many variables associated with this, according to how fast we will sunburn. Certainly pigmentation of the skin is a big one. Time of day, humidity, wind, cloud cover, and altitude. Aging of the skin. This is primarily caused by UVA rays. These penetrate deeply into the skin and damage the collagen layer, which is the supporting layer of the skin. It also can change the pigmentation, causing splotchy or freckly discoloration of the skin. This is caused not by age, but by the sun. If you look at your forearm, where on the back of it, where it's seen the sun for years, it looks aged. But if you turn your arm over and you see the nice evenly colored skin, it looks younger and it looks healthier. But both sides are the same age. It's really the sun that does it. Pigmentation is the production of melanin in the skin. This is nature's ideal sunscreen. Its production in the skin evolutionarily has varied by latitude. This shows the Africans versus the fair northern Europeans. These changes, it is thought, may have developed as a response to vitamin D formation. In northern latitudes, where there's much less sun, it is harder to produce adequate vitamin D, and you don't want much melanin to block any potential rays from the sun which can form vitamin D. In the equatorial regions, however, vitamin D could be overproduced, leading to toxicity. Vitamin D is a fat-soluble vitamin which is stored in the body. African Americans in the US, which this is not where they originally came from, are frequently found to be low in vitamin D since their skin blocks so much of the ultraviolet. Consequently, people like me don't belong in Florida where they didn't come from. Nowadays, vitamin E is easily supplemented either in pill form or foods which are supplemented, such as milk, which is nowadays fortified with vitamin D. There are three main types of skin cancer. The first is basal cell carcinoma. This is the most common cancer in the US. It is estimated that there are 2.5 million cases per year of this in the US. These most commonly occur on sun-exposed areas, mainly the face, neck, ears, and upper back. This shows some of the ways they can look. These occur mainly as pink bumps, which bleed easily, or just as flat pink patches. Although they may sometimes have some pigmentation, much less commonly. None of these pictures show that. These are the typical sore that does not heal, which traditionally we've all been warned about as a sign of cancer. These almost never spread. Why bother to treat them then, you may ask? These can be very destructive. I spared you the very unpleasant pictures of looking at ears or noses totally destroyed or eaten away by these cancers, or eye sockets full of tumor, which constantly bleed. Certainly it takes a great deal of neglect for these basal cell carcinoma to reach these kinds of stages. As you can imagine, treating these advanced cases is rather difficult, but the earlier they're treated, the easier they are to deal with. Treatment is primarily by surgery. They are commonly scraped and cauterized, which is called electrodesiccation and curettage. They can also be excised, that is, cut out and stitched up. Mohs surgery is another technique used in more advanced cases, recurrent lesions, or in high-risk areas, for example, near the eye. In Mohs surgery, the lesion is cut out, then mapped and cut up like a pie. Each piece is then examined under the microscope. If the margins are not clear of tumor in any particular piece, the surgeon then goes farther out or deeper as needed, and the pieces are re-examined again until clear margins are achieved all the way around. This procedure certainly is much more expensive and time-consuming, so it's not for the routine basal cell carcinoma. Radiation is another treatment option, which is much less popular today than it was years ago. Now it tends to be used more in elderly patients who are a high surgical risk, or in any other areas in elderly people which are much more difficult to treat. It must be done over a period of time, usually daily for about a month. The cosmetic results can result in atrophy of the skin, which can grow worse as time progresses. It can also encourage the growth of further skin cancers as time goes by. Another new treatment, which uses a medicine called imiquimod, is an immunotherapy, which causes the body's own immune system to get rid of the tumors. At this point, this is really only used for extremely superficial tumors, but it's really a promising step in a new direction, trying to get the body's own immune system to get rid of the tumor all by itself. Another beauty of this kind of treatment is it leaves absolutely no scar. The second most common type of skin cancer is squamous cell carcinoma. These are crusty or warty bumps, which may, again, bleed. Sometimes they can be painful. These occur, again, mostly on the face and neck and ears, but they also on the hands and arms more so than basal cell carcinomas do. Solar or actinic keratoses are a precancerous form of squamous cell carcinoma. These are reddish, rough areas, which often can be felt more than seen. Again, face, ears, hands, and arms are where they most commonly occur. Squamous cell carcinomas can spread, but the common small ones in relatively healthy people rarely do. Larger lesions or lesions in high-risk areas, such as the lower lips, can spread. These spread more commonly in patients with long-term immunosuppression, such as transplant patients who have to be extremely cautious with skin cancers. Fatal metastatic cancers certainly can and do occur in post-transplant patients. Treatment, as with basal cell carcinoma, is similar, primarily surgical. Treatment of metastatic disease now shows more promise as new drugs are being developed, which often show great effectiveness. Melanoma is the third most common type of skin cancer and certainly the most serious of the three, since it can be deadly. It most commonly occurs on the torso, arms, legs, or the face. It can spread to local lymph nodes and then to internal organs. Those at the highest risk are older men. Those of the white race, especially with fair skin, red or blonde hair, blue or green eyes, are also at high risk. A history of previous basal or squamous cell also increases one's risk, and having a previous melanoma certainly increases the risk of a second one. Screenings, especially in high-risk individuals, can definitely lower the mortality rate. Studies in Germany have definitely shown this by identifying lesions at an earlier stage. The trick is really to find these lesions early before they have a chance to spread. The early lesions are more superficial, and it's not until they grow deeper in the skin that they're able to spread. Screening is key. What we're looking for, both doctors looking for and non-medical people looking at themselves, are summarized in the ABCDs of melanoma. Firstly, asymmetry. If you look at this normal mole on the left, if you did a diameter, any half looks the same as the other half. This isn't the greatest picture at this magnification, but probably shows better in some of the other pictures. If you cut it in half this way, it's asymmetrical on both halves. The borders are uneven. Again, on the left is a normal mole, on the right is the melanoma. You see the asymmetry better in this particular picture. C is for color. One color in the normal mole versus multiple colors in the melanoma seen on the right. Again, these are general principles. You can certainly see multiple colors in a normal mole, but it's a general sign to watch out for. D is for diameter or size. Generally smaller than 1/4 of an inch in a normal mole, larger in the melanomas. Again, this is probably not the most reliable sign. Certainly normal moles, especially those that have been there nearly your whole life, often going to be much larger, but one of the guidelines. E is for evolving or changing. Certainly changes growth in size, changing shape, changing color, obviously bleeding or itching. These are signs to watch out for. Most of these signs that I've discussed are those of the superficial spreading melanoma, the most common type. It grows across the surface of the skin before it grows downward. There's a less common type of melanoma called a nodular melanoma, which initially just grows straight downward in the skin, at which chance it has when they're growing deeper, then they have a chance to spread. These are much tougher, the nodular melanomas, to identify in time. Therefore, they have a worse prognosis. There is another sign called the ugly duckling sign. A particular spot, a particular growth does not have a matching mate that looks like it elsewhere on the skin. A dark color of a mole doesn't necessarily mean anything if a person has similar looking dark darkly colored moles. There's another type of melanoma, fortunately less common, called an amelanotic melanoma, having no pigmentation. These present as a pink spot. They're very tough to diagnose in time. When biopsies of these are taken, they're usually sent into the pathologist with a clinical diagnosis of a basal cell carcinoma. These are the ones that keep dermatologists awake at night. Very tough to spot in time. Fortunately, they're less common, much less common than the pigmented melanomas. Dermatologists can hopefully identify a melanoma in an earlier stage before they get to look like the classical textbook pictures that I showed you. This picture shows a dermatoscope, which is something that can be used. It's a light with a 10 times magnifying lens, which can be helpful to distinguish between the normal pigment network pattern in a normal mole versus the irregularity that's seen in a melanoma, something that can be helpful to distinguish between the two. Unfortunately, it's not quite as straightforward as it sounds, and it's not a foolproof sign of benign or malignant, but it's another tool that can be helpful. The primary treatment for melanoma, as in the other skin cancers, is surgery. The treatment of advanced melanoma is finally starting to show some promise. Many new drugs have been developed, and many more are being worked on, as research in the field is very, very active. The most promising approaches involve immunotherapy, in which the body's own immune system is harnessed to fight the tumors. These methods, which use the body's own defenses, have in some cases shown some very spectacular results, but they're really not fully perfected at this time, and at this point certainly don't work in all patients. But it's most encouraging to see some progress where there had been a invariably dire outcome just a few years ago in this condition. Unfortunately, melanoma rates are on the rise. In the year 2000, there were about 47,000 cases diagnosed of melanoma in the United States. It's estimated that in 2014, there were 140,000 cases diagnosed. It's also estimated that 10,000 Americans died in 2014 from melanoma. With melanoma, in addition to sun exposure, there are genetic risk factors involved. As I said before, a positive family history certainly can raise your risk. So it's not strictly the sun. There are other factors as well. Indoor tanning is certainly another risk factor for melanoma. An estimated 28 million Americans use tanning machines. A 2011 study in Minnesota showed a 41% increase in melanoma risk among people who had ever done indoor tanning versus those who never had. Changes in the ozone layer may also contribute to the rising skin cancer rates. But probably one of the biggest contributors to this rise is lifestyle. Early in the 20th century, clothing covered the body from head to toe. Ladies often carried parasols, and women often wore gloves. Hats were extremely common. I remember when I was young, my father would never leave the house without wearing a brimmed hat. Years ago, white skin was considered more appealing than tan skin. Tan was associated with field workers. Ladies did not want a tan, nor did they want freckles. Attitudes changed as tan became associated with a leisurely upper-class lifestyle, as well as a sign of good health. Pale skin became associated with factory workers who spent long hours working indoors. Medically, also in the earlier 20th century, sunshine was accepted as a treatment and prevention for rickets, which is a vitamin D deficiency, associated with severely bowed legs, among other problems. It was also considered a treatment for tuberculosis. Patients were sent to sanatoriums and placed out in the sunshine. It therefore gained a reputation as generally good for you. And certainly sure you can remember your parents urging you to go out and get some sunshine. It was good for you. With more leisure time and generally rising rates of prosperity, people spent more time at the beach, especially with less and less cover. Sportswear also covers less these days. Men used to play tennis in long white flannel pants. Ladies played field hockey in long skirts and dark stockings. Found a picture of also bonnets that they wore. Travel has also become more frequent. Now it seems like any child who hasn't been to Disney World at some point is an underprivileged child. The rise of affordable air travel for the middle class has made a huge difference in the American lifestyle, leading to more sun exposure, more exposed skin, and more skin cancer. What can we do to protect ourselves? Hats, shirts, avoiding the midday sun, especially from 10 to 2. Sunscreens. These are both chemical and physical blockers of the ultraviolet light. There are two types. There are organic sunscreens, which absorb ultraviolet light. There are PABA derivatives. Regular PABA is really not used anymore. Oxybenzone, salicylates, and cinnamates. Derivatives of those things are the main organic sunscreens that are used nowadays. They can block both UVA and UVB. There are inorganic sunscreens, and they reflect rather than absorb the ultraviolet rays. These are titanium dioxide and zinc oxide. The advantage is these are non-allergic, but they are less cosmetically elegant. Many people find them hot to wear. They're better than they used to be. The micronized particles have replaced the old-fashioned paste that the lifeguards used to wear on their nose, so they're not as bad as they used to be, but some people don't like them too well. SPF stands for Sun Protective Factor. I wish I had $1 for every time a patient has asked me, "Doctor, do I need more than a 15 sunscreen?" That's a complicated question. Sun Protective Factor is defined by the FDA as the factor of sunburn protection by a sunscreen. For example, if someone is sunburned in a given, let's say noonday sun in 15 minutes, if they had a factor for a sunscreen, it would take them 4 times as long. So rather than 15 minutes with their factor 4 sunscreen, they would sunburn in 1 hour. So that's how it works. But the way the FDA has defined this, it's defined by a rate of application of 2 milligrams per square centimeter of skin. I'm sure that means absolutely nothing to you, but what that works out for an average-sized adult male, would be to apply 1 1/4 ounce of sunscreen per application on your body, if you're going to the beach. That's about 1/3 of a normal 4-ounce tube of sunscreen. Nobody, not even me, applies that much sunscreen. Applying it that heavily, it's nearly impossible to rub it in. At that rate of application, it is just ridiculous. Therefore, you have to use, depending on how you're using it, you have to use maybe an SPF 60 or maybe an 85 to wind up getting an SPF of 15 at a normal rate of application. So in answer to that question, you may not need more than an SPF 15 if you're going to be out for an hour or two, but you need to get an SPF 15. It's also important to reapply sunscreen as you go along if you're going to be out in the sun for any length of time. As the ladies here know, when you put on makeup, it seems to vanish. Heaven only knows where it goes, but it goes. It's the same with sunscreen. You put it on, after a while it's gone. It's one of life's mysteries. So, in conclusion, is the sun friend or foe? I'm sure we all have friends who may have a kind of a difficult side. You have to be a little careful around them at times, but they're still our friends. The sun is like that. It's a great friend. We wouldn't be here without it. But you have to just be careful. I want to thank my daughter who made all these pictures possible. I know something about dermatology, but I know nothing about PowerPoint. So she helped me out at Christmas time when I was up north. So thank you all for your attention, and I hope that you'll have some questions. I'll do my best to answer them. Okay, any questions? Okay, in the back.